Now, let's talk about pre-implantation genetic screening. I've also made a video explaining what this means. Pre-implantation genetic screening is used to check embryos for abnormalities in the number of chromosomes. So this is done by taking out some cells from an embryo on day 3 or some part of the trophectoderm on day 5. So the embryo with abnormal number of chromosomes, they have less chances of developing into a baby and may result in a baby being born with a genetic condition. The risk associated with PGS is that although current PGS procedures are mostly very accurate, the test may give the wrong result. So it may miss an abnormality or detect one that is not there. So you might throw away a very healthy embryo, or you might keep an embryo that is defective. And also using PGS may mean that you have fewer embryos to use for your treatment, or you have fewer embryos to freeze to be used in later dates. So if any embryos that you have, if any embryo is discarded during this period, you would have fewer chances of transfer with an embryo which could have developed into a healthy baby. Also, remember that you are removing cells from this embryo, and removing cells from this embryo may damage the whole embryo entirely, and that embryo might not be able to self-repair, or that embryo might not be able to develop properly, and that would obviously prevent it from successfully developing, implanting, or when it's transferred back might not lead to a clinical pregnancy. Removing part of the embryo may also cause changes in later growth in the womb, and which may also cause problem in later life. In some cases, cells within the embryos are not chromosomally identical, which is referred to as mosaicism. So they call them mosaic embryo. So which means that PGS may show that the embryo has chromosome abnormalities when in fact it's capable of producing a normal pregnancy, or vice versa. In some clinic, mosaic embryos are actually considered for transfer, whereas even though they show some chromosomal abnormality, some of these mosaic embryos go ahead to make healthy live babies. In the past, PGS was actually traditionally offered to just people who are over 37 years of age, or couples that who've had several miscarriages or failed IVF cycles. People with a family history of chromosomal problems, and men whose sperm may carry abnormal chromosomes. So the cells were removed from the embryos at the 8 cell stage on day 3, and also there is no evidence to show that this type of PGS is beneficial for this group. In fact, studies have shown that this type of PGS can actually reduce the success rate, probably because of the damage done to the embryo. Small studies have also shown that PGS carried out at a later stage, like the blastocyst stage on day 5 or day 6, might be helpful in selecting viable embryos to transfer in younger patients who are typically under 37 with no history of miscarriage or failed IVF cycles. It's important to kind of understand that PGS will not increase your overall chance of having a baby. It may help to reduce the likelihood of having a miscarriage, but more evidence is needed to confirm these findings, right? So when considering whether to have PGS, you also have to think about the cost associated with PGS, because I really like the science behind pre-implantation genetic screening, but supporting the notions that it's been a standard of treatment for every patient is kind of it doesn't really sit well, right? Does every patient really need to do PGS? The answer is absolutely no, but some patients would benefit from PGS, those who've had series of miscarriages, family history of chromosomal abnormalities and all that stuff. Should it be the gold standard? No. Is it beneficial? Yes. So for PGS, it's a red flag for day 3 screening, because there is no evidence that shows that this add-on is effective and safe. And it's an amber for day 5 or day 6 biopsy screening because of the conflicting body of evidence for this add-on. I'll also definitely update you guys when there is an improvement in PGS. Stay tuned. Talking about intrauterine culture, so most people now these days want to go solo, or they want to go minimalistic, or they want to just make things, very personal, which I don't have any issue against. During a conventional IVF, eggs are fertilized and allowed to develop in a special culture fluid inside the incubator. You can check out my video on IVF. With intrauterine culture, the egg and the sperm are collected, fertilized, and they are now placed back into the uterus, right? They are placed back into the uterine culture device, which is now inserted back into the woman's womb. The device is left there for several days or hours during the initial stage of embryo development. When the device is removed, the embryo are put in an incubator until they are able to be transferred back into the womb or frozen for future use. The idea for this sort of add-on is to provide an optimal temperature for the embryo. That's why they put that embryo back into the uterus. There is currently very little evidence exploring the potential risk in actually using these devices. So it's worth mentioning that the womb is not the right place in the body for the embryo to develop at that stage, right? So normally it would be developing in the fallopian tube. So for this add-on, it's unfortunately a red flag because there's currently no evidence to show that intrauterine culture improves birth rate and that intrauterine culture is safe. This is something you may wish to consider if you're offered intrauterine culture at no additional cost. All right, the next one is artificial egg activation. When a sperm meets an egg, it activates the mature arrested egg into a fertilized oocyte. Then it becomes an embryo. If the egg doesn't activate, then it won't fertilize or it won't develop. Egg activation may be stimulated by chemicals called calcium ionophores, which can be added in the lab. In theory, egg activation using calcium ionophores could cause embryo damage, could cause embryos to have abnormal numbers of chromosomes, which could now cause the pregnancy to miscarry. As yet, there is not enough evidence to decide whether these risks are of serious concern. Given the possible risk, the treatment is only feasible in selected patients who've had failed fertilization. So let's say for example, you have 20 eggs and you went for an ICSI, not IVF, and you had no fertilization. Then this treatment might be beneficial for you. Calcium ionophores should only be used where there is total fertilization failure or fertilization rate less than 5%. There has been few studies done to date, and egg activation using calcium ionophores may improve fertilization rates in ICSI cycles where the egg and sperm have failed to activate in previous treatment cycles. There are no random controlled trials to show that it's effective. Follow-up studies is needed for this guy, right? So for this guy, it's an amber. Except when you have total fertilization failure or a fertilization rate less than 5%, then you might consider using calcium ionophores. It shouldn't be a standard of care. Okay, finally, let's talk about time-lapse imaging. In IVF, time-lapse imaging is used to help select the embryo most likely to successfully develop into a baby. In conventional IVF, the embryologist would check the developing embryos each day under the microscope just to see how the embryo is doing, and it involves removing the embryo from the incubator, looking under a microscope and putting the embryo back into the incubator for a brief period of time. Time-lapse imaging, however, allows the embryologist to just, take thousands of images of the embryo and actually monitor the embryo as they grow without taking out the embryo from the incubator, exposing the embryo to ambient temperature, putting the embryo under a microscope, exposing the embryo under light, and all that stuff. You also prevent the risk of dropping the embryo, the dish, when you take out the dish from the incubator. It gives the embryologist a powerful ability to see how the embryo is doing and actually monitor the time lapse basically of the embryo, because you as an embryologist, you don't look at the embryo throughout the day. So there are certain things you could miss during the developmental stages of the embryo that you can actually catch using the time-lapse imaging machine. So when you have all this information, then that would guide the embryologist to choose a specific embryo for implantation based on criteria such as the rate of development, the number of PNs or pronuclei, and the appearance of cells. This also, like I said, reduces the accident rates and keeps the temperature intact during the time of culture. So there's actually no risk associated with using time-lapse. There have been various studies to try and see if time-lapse imaging can improve birth rates. Initially, the research has shown some promise, but it's still in the very early days. So some clinics actually offer these videos to clients at an additional cost, or if you want your embryo to be put in a time-lapse machine, you might want to pay more. It's a beautiful technology, no doubt, and it would make the life of every embryologist obviously easier. But for this guy, it's an amber, indeed, being undisturbed while they grow may improve the quality of the embryo, but there is certainly not enough evidence to show that time-lapse imaging improves birth rate, which is something you may want to consider if you have been offered, time-lapse imaging at an extra cost. If it's free, go for it. But if they are asking you to pay for it, you might really want to consider, do I really need time-lapse, or do I just want a conventional IVF plus ICSI? Finally, guys, the last one is physiological intracytoplasmic sperm injection. So this is called PICSI. So PICSI is a technique used to select sperm to use in ICSI treatment. So it involves placing sperm with hyaluronic acid. So hyaluronic acid is a neutral compound in the body. So PICSI identifies the sperm that can bind to hyaluronic acid, and these sperm are now selected for the use in treatment. Risk-wise, it's non-invasive procedure performed on sperm sample before the injection. So they've actually been a number of studies comparing PICSI and standard ICSI, and there is little evidence to suggest that there is any benefit using PICSI. A large randomized study was recently carried out, and it showed that using PICSI did not increase the chances of having a baby when compared to the conventional ICSI. On this one, it's a red, guys. It's a red for me. It's a red on PICSI. So there you have it. That's all. This is all from me today, and stay connected. If you really go into an IVF clinic and they show you some add-ons, I would recommend you ask for scientific evidence to show that those add-ons would improve your cycle. And yeah, basically, and if there is no strong scientific evidence to show that that would improve your cycle, then you might just want to skip that add-on. People might just pop up numbers from their head that, oh well, this would give you a 50% increase or a 90% increase or whatever. Make sure you have at least 3 randomized trials. Thank you so much for watching, and cherish life.